Welcome to the RadOnc Smart Review GI Cancer series.
Great to be here.
Today we're tackling a really fundamental topic, but one with so much nuance. Rectal cancer, specifically focusing on getting from simulation to a safe treatment plan.
Yeah, it's crucial. We've laid a lot of groundwork in previous sessions.
Exactly. We've talked anatomy, staging, the surgical side, those big trials.
The total neoadjuvant therapy or TNT shift.
Right, and all the talk about organ preservation, de-escalation, that kind of thing.
So today is about putting it all together, taking that knowledge and actually, building the plan, a high-quality plan.
That's the mission. How do we translate understanding into practical steps?
Precisely. And it's one thing to know the rules, another to apply them. So let's use a case to make it real.
Good idea.
Okay, picture Mr. Chen. He's 68. He's got a clinical T3N1 midrectal adenocarcinoma. It's located, say, 8 centimeters from the anal verge. And importantly, his MRI. It shows a clear circumferential resection margin, the CRM. So he's lined up for neoadjuvant, long-course chemoradiation.
Standard scenario.
Very standard. So our job, starting now, is designing his plan. Safe, effective. And it begins, really, before he even gets on the table. It starts with simulation setup.
Ah, yes, the simulation. It really is the foundation, isn't it?
Yeah.
Get that wrong. And everything that follows is compromised.
You got it. And that foundation starts with patient prep and education, even before the sim appointment.
Making sure Mr. Chen does exactly what to do.
For reproducibility. Right. And OAR sparing.
Absolutely. Reproducibility is the name of the game here. So for Mr. Chen, and really for all our pelvic radiation patients, we have these specific protocols, bladder and rectal.
Let's break down the bladder one first.
Okay. So 1 hour before the simulation appointment, and then 1 hour before every single treatment session, the instruction is, first, urinate. Empty the bladder completely. Yeah. Then, right after that, drink about 2 cups of water. That's around 20 ounces. Got it. Urinate, then drink.
Yep. And then this is the key part. Do not urinate again until after the scan or the treatment is done. Hold it.
And there's a very specific reason for that, isn't there? It's not arbitrary.
Not at all. A consistently full bladder, it acts like an internal spacer. Think of it like a water balloon inflating in the pelvis.
Okay.
It gently pushes the small bowel loops, which are really mobile, it pushes them superiorly, kind of up and out of the main radiation field.
Oh, so it protects the small bowel.
Exactly. It reduces the volume of small bowel getting high dose. Super important for cutting down side effects, both the acute ones and the late ones.
Okay, so that handles the bladder, the internal spacer. What about the rectum itself? That needs to be consistent too, right?
This is important. So the rectal protocol. We ask patients to try and have a bowel movement within, say, 4 hours before simulation and each treatment.
Empty the rectum.
And then about an hour before they come in, try to pass any gas, any flatus, get the air out.
Makes sense.
Now, here's a really important point we have to stress to patients. No prophylactic enemas.
Right. I've heard residents ask about that. Why specifically no enemas if the goal is an empty rectum? Seems counterintuitive.
It does seem that way, but enemas can be unpredictable. They can sometimes cause the rectum to get overly distended or cause spasms or just fill inconsistently.
I see.
Our goal isn't just an empty rectum. It's a consistently empty or at least consistently filled rectum. We want it to be in the same position, same shape every single day. Natural emptying is usually more consistent than an enema-induced one.
Because if the rectum is distended differently each day,
then the target, the tumor itself, can shift position. You could end up undertreating the tumor or overtreating normal tissue. It's a setup uncertainty we can minimize with good prep. Geographic miss is a real concern.
Okay, clear. So bladder full, rectum empty, inconsistent. What about the chemo side? If Mr. Chen's on oral capecitabine with his radiation, any special instructions there?
Good point. Yeah, for capecitabine, we tell him, take it only on the days you get radiation, usually Monday through Friday. No chemo on the weekends.
Okay.
And this is a big clinical pearl. Avoid taking proton pump inhibitors, PPIs, like omeprazole at the same time.
Why is that?
There's some concern and data suggesting PPIs can interfere with how well capecitabine gets absorbed. So it might reduce the chemo's effectiveness. We want that chemo working alongside the radiation.
Important interaction to catch. And labs.
Oh, yeah. Standard weekly labs during long course, a CBC, complete blood count, and a CMP, comprehensive metabolic panel, just to monitor for any hematologic or metabolic issues from the treatment. Keep an eye on things.
Okay, patient prep nailed down. Now, Let's get Mr. Chen on the table. Positioning, imaging choices, these really matter. What's the go-to for him?
So for most rectal cancer patients like Mr. Chen, we strongly prefer simulating them prone, face down, and specifically on a belly board.
Explain the belly board rationale.
Right. So the belly board has an opening. When the patient lies prone, their abdomen sags down into that opening. And gravity becomes your friend. It helps pull those mobile, small bowel loops anteriorly away from the back and also superiorly up towards the head.
So again, moving the bowel out of the target zone.
Exactly. Compared to lying supine, face up, the prone belly board position consistently reduces the amount of small bowel that gets hit with higher radiation doses. It's a really effective OAR sparing technique built right into the setup.
But what if someone just can't tolerate being prone? It happens. Is supine okay?
Yeah, absolutely. Supine is definitely an acceptable alternative if prone isn't tolerated.
Okay.
And there's one situation where supine is actually preferred. That's if you need to cover the inguinal lymph nodes.
Which you wouldn't typically need for Mr. Chen's mid-rectal tumor.
Correct. But if you had, say, a very low tumor involving the anal canal, you might need inguinal coverage. In that case, supine is better, often with the legs slightly apart, kind of a frog leg position, to open up the groin area for the radiation fields.
Got it. So prone preferred, supine acceptable, or needed for inguinal nodes.
Yeah.
Now, the scan itself, what's the protocol?
We get a CT scan, and we use intravenous contrast. Helps delineate vessels and tissues.
And how far down do you scan?
Critically important. You have to scan low enough to clearly include the anal verge, the absolute bottom of the target area.
Do you ever mark the verge externally?
Yeah, sometimes placing a small external marker like a radiopaque wire right at the anal verge can be really helpful. Just ensures you can pinpoint it accurately on the planning scan.
Okay. And for image guidance during the actual treatments?
Standard practice now is daily kilovolt imaging, KV imaging, like orthogonal x-rays. That verifies the bony alignment is correct each day. Simple, quick setup check.
And cone beam CT?
We typically do weekly cone beam CT or CBCT. This gives us a 3D picture right before treatment. It's crucial for checking things that KV imaging can't see well, like
Bladder filling, rectal distension.
Exactly. Is the bladder still full like it was at SIM? Is the rectum still relatively empty? If we see significant changes week to week on the CBCT, we might need to adapt the plan.
Makes sense. What about fiducials? Sometimes we hear about implanting markers.
Yeah, that's usually for more specialized situations. If you're doing something like SBRT, stereotactic body radiation therapy, with very tight margins, or perhaps in an organ preservation case where precision is absolutely paramount.
Then fiducials help?
Then implanting small fiducial markers near the tumor before the simulation can be really beneficial. They act like tiny GPS beacons, allowing for incredibly precise daily targeting using the CBCT or even KV imaging, better accuracy for those highly conformal plans.
Okay, so Mr. Chen is prepped, positioned, scanned. Now we move to the planning computer, the art of contouring, defining the targets. You mentioned a wedding cake approach.
Yeah, I like that analogy. You start with the smallest, most definite layer, the known disease, and then you build outwards, adding layers for areas at microscopic risk. It's systematic.
So layer one,
Right.
the gross tumor volume, GTV, for Mr. Chen.
Right. The GTV has two parts for him. First, the GTV primary. This is the tumor you can actually see. We define it using everything we have, the physical exam findings, what the endoscopist saw, and critically, the diagnostic imaging.
And this is where the MRI fusion comes in.
Absolutely essential. We strongly recommend fusing the diagnostic pelvic MRI, particularly the T2-weighted sequences, to the simulation CT scan.
Why T2 specifically?
T2 imaging gives you fantastic soft tissue contrast in the pelvis. It's the best way to see the extent of the tumor within the rectal wall, whether it's threatening that circumferential margin, and helps identify suspicious nodes. Fusing it gives you the anatomical truth laid over your planning scan. Optimal GTV definition.
GTV primary. What's the other GTV part?
GTV nodes. So any lymph nodes that look frankly involved on the imaging, maybe they're large, have suspicious features on MRI, those get contoured individually as GTV nodes.
Got it. Innermost layer done. Now, the next layer out, the clinical target volume, standard risks, CTV-SR. This is the bigger volume, getting typically 45 gray.
Exactly. The C2B-SR is designed to cover the entire primary tumor region, plus areas at risk for microscopic spread that we can't necessarily see. It includes the entire rectum itself, the mesorectum, and those key regional lymphatic bases. For long course, like Mr. Chen's, 45 gray in 25 fractions is the standard dose to this volume.
Okay, so walk us through contouring that CTV-SR. What are the key structures and boundaries for his midrectal tumor?
First, you contour the entire mesorectum. That's the fatty envelope surrounding the rectum. It contains the primary tumor, yes, but also all those perirectal lymph nodes. You got to cover the whole thing.
Okay, the whole mesorectum, inferior border.
For a midrectal tumor, you typically go down to the pelvic floor muscles. Anatomically, you can often see it as where the mesorectal fat kind of disappears or tapers. As a rule of thumb, you want to be at least 2 centimeters below the lowest extent of the gross tumor, whichever boundary is more inferior.
And if the tumor was much lower down, say involving the sphincter, or if an APR, an abdominal perineal resection, was planned?
Good point. Then the inferior border changes significantly. If an APR is planned or the sphincter is involved, you absolutely must include the entire anal sphincter complex, the perianal tissues around the anus, and those discrectal fossae, the fatty spaces on either side. Much broader coverage inferiorly.
Okay. Superior border for Mr. Chen.
Superiorly, we generally extend up to the L5-S1 inner space, the start of the sacrum. Or, again, make sure you're at least 2 centimeters above the highest extent of the gross tumor, whichever is more superior.
Anterior border. Towards the bladder.
You include all of the mesorectum anteriorly. And here's a practical tip, a clinical pearl for planning. Always add about a 1 to 1.5 centimeter margin into the posterior aspect of the bladder wall.
Why into the bladder?
It accounts for day-to-day variations. Bladder filling isn't always perfect. The rectum might shift slightly. That little margin into the bladder ensures your anterior mesorectal target remains covered even with those small shifts. It's a safety margin.
Makes sense. Laterally.
Laterally, you generally extend just a few millimeters beyond the levator muscles. And crucially, you must include the internal iliac lymph node basin.
And the elective nodal volumes within that CTVSR. Which ones are standard?
Okay, for elective coverage in the CTVSR, definitely the presacral nodes. You cover that entire presacral space. Think of it as about a 1 centimeter rind of tissue, just anterior to the sacral bone. Very important area for recurrence.
Right.
Then, the internal iliac nodes. We typically cover these by drawing about a 7 millimeter margin around the internal iliac vessels, starting where they branch off the common iliacs and following them down. And the obturator nodes, which are down lower in that same region, are also included in this standard volume.
So mesorectum, presacral space, internal iliac obturators. That's the core CTVSR.
That's the standard package for a tumor like Mr. Chen's.
Now, you mentioned earlier special or conditional nodal considerations. These aren't included for Mr. Chen, but when do they get added?
Right. Good distinction. These are exceptions, not the rule.
No.
External iliac nodes. You only include those if you have a T4 tumor that's directly invading into anterior pelvic organs like the bladder or the prostate. The tumor has to be growing forward significantly.
Okay. And inguinal nodes?
Inguinal nodes are only included if the tumor extends below the dentate line in the anal canal or significantly involves the anal canal itself. Usually this means the tumor is very low, maybe less than 4 centimeters from the anal verge. It's about the drainage pathways for those very low tumors.
So those are conditional, based on specific invasion patterns.
Got it. Now back to the wedding cake. We've got the GTV, the CTV-SR. What's the next layer? The boost volume.
Yep, the final clinical target volume layer. The CPV high risk, or CTV-HR, this is the volume that gets the higher dose, the boost.
How do we define that?
At a minimum, the CTV-HR includes the GTV primary and any GTV nodes, plus you add a margin of about 1.5 to 2 centimeters in the superior and inferior directions.
Okay. And within those superior-inferior boundaries, it should encompass the entire rectum and the mesorectum at those levels. And don't forget the presacral space, or that sacral hollow behind the rectum at those levels. That needs to be in the boost volume too.
What if it's a T4 tumor invading something?
Ah, yes. For a T4 tumor, you'd also add a 1 to 2 centimeter margin into whatever adjacent organ is being invaded as part of that high-risk volume.
I've also heard some experts advocate for a slightly different, maybe more comprehensive boost approach.
Yes, there's definitely a school of thought, and I tend to agree with it, that strongly considers boosting the entire mesorectum and the adjacent presacral space to the full boost dose.
The whole thing.
The whole mesorectum, from top to bottom as defined in the SR volume, plus the presacral space. What this often looks like is a volume pretty similar in shape to the CTVSR, but importantly, you don't include the elective superior nodal coverage, like upper internal iliacs or the wider lateral margins in that boost.
Why do that?
The rationale is to deliver the highest dose to the entire anatomical compartment where the primary tumor arose and its most immediate drainage, really maximizing the chance of local control in the highest risk area without unnecessarily boosting more distant elective nodes.
Interesting approach. Okay, so we have our CTVs defined. The final step is the planning target volume, PTV. What's the purpose of that margin?
The PTV margin is that final expansion around the CTVs. It's purely a geometric margin to account for uncertainties. Things like small errors in daily patient setup, organ motion during treatment, maybe slight breathing effects.
It's the safety net.
Exactly. It ensures that despite these small, unavoidable day-to-day variations, the prescribed dose actually covers the intended clinical target volume. For modern setups using daily image guidance like KV or CBCT, a PTV margin of about 0.5 to 1 centimeter around the CTVs is pretty typical.
Great. Volumes defined. Now let's talk dose and fractionation. Highly individualized, you said, but there are common schemes. Back to Mr. Chen. Neoadjuvant long-course chemoradiation. What's the standard prescription?
Okay, for preoperative long course, the standard is the CTV SR, that larger volume, gets 45 gray, delivered in 1.8 gray fractions. That's 25 fractions total.
Okay.
Then the CTV-HR, the boost volume, is typically taken to a total dose of 50.4 gray, also using 1.8 gray fractions, so that's an additional 3 fractions for 28 fractions total. Standard for T3 or node-positive disease like his.
50.4 and 28 fractions. That's the classic long course dose.
That's the classic.
But you mentioned IMRT earlier, and this simultaneous integrated boost, or SIB, approach. That's becoming really common, isn't it? How does that work?
SIB is a very elegant and efficient way to do it, especially with IMRT or VMAT techniques. Instead of treating the 45 gray volume first, then doing a separate plan and treatment phase for the boost,
You do it all at once.
you deliver different doses to different target volumes simultaneously in the same fraction using a single plan. So for Mr. Chen, an example SEB approach might be deliver 50 gray total dose at 2 grays per fraction to the PTVHR, the high-risk boost volume.
Okay, higher dose per fraction there.
Right. And at the same time, in the same treatment session, deliver 45 gray total dose, maybe at 1.8 gray per fraction, to the PTVSR, the standard risk volume, excluding the HR volume. All done in, say, 25 fractions total.
So you finish treatment faster than the sequential boost method.
Exactly.
Yeah.
And that's one of the big advantages.
Can you give us that analogy again? Yeah. The oven one? It was helpful?
Oh, right. Think of SIB like a really advanced multi-zone oven. You know, instead of baking your main course like a roast chicken at one temp, taking it out, then cranking up the heat to bake potatoes separately.
Yeah.
With SIB, it's like putting both the chicken and the potatoes in the oven at the same time. The oven is smart enough to deliver precisely the right amount of heat to each zone, so the chicken cooks perfectly at its temperature and the potatoes cook perfectly at their slightly higher temperature all simultaneously.
Finishing together.
More efficient.
Way more efficient.
Yeah.
Faster, more precise heat distribution. Same idea with SIB for radiation doses.
And the benefits go beyond just saving time,
Yeah.
right? Oh, definitely. Reducing the overall treatment time, like going from 28 down to maybe 25 fractions, is great for patient convenience and compliance. Less time coming in.
Fewer trips.
Fewer trips. Plus, reducing treatment time might have a biological advantage, potentially reducing the chance for tumor cells to repopulate during treatment.
Ah, interesting.
And from a planning standpoint, optimizing one SIP plan can often lead to more conformal dose distributions compared to summing two separate plans. You can potentially achieve better OAR sparing and get a smoother, more controlled dose fall-off between the high-dose and low-dose regions. It's just a cleaner, more integrated approach.
Okay, SIB makes a lot of sense for a long course. What about the other major neoadjuvant approach? Short course radiation, how does that compare?
Totally different beast. Short course radiation therapy, sometimes called the Swedish style, involves delivering 25 gray total dose, but in only 5 fractions.
Wow, 5 gray per fraction.
Exactly. A much higher dose per fraction delivered over just 1 week. It targets the CTVSR, that whole elective pelvic volume.
And concurrent chemo with short course?
Typically, no. Short course is usually radiation alone. And another key difference, there's generally no primary tumor boost incorporated into the short course regimen. It's just 25 and 5 to the elective volume.
Very different philosophy. Okay, shifting gears to postoperative radiation. Different scenario entirely. When do we use this?
Post-op radiation comes into play mainly if a patient had surgery up front, maybe because their initial staging didn't seem to warrant neoadjuvant therapy, but then the final pathology report comes back with some adverse features.
Like what kind of features?
Things like positive surgical margins, that's a big one, or maybe close margins, extensive lymphovascular invasion, or perhaps a higher T or N stage than expected, like finding positive nodes pathologic N1 or N2, even if the margins were negative.
Okay, so if margins are negative, but there are other adverse features, say PT3N0 with LVI, or maybe PT12N1, what's the dose?
In that situation, negative margins but other risk factors, the standard is PTV-SR gets 45 gray at 1.8 gray per fraction. Then you add a boost to the PTV-HR, which is typically the surgical bed area deemed at highest risk. That boost usually goes to 54 to 55.8 gray total dose, using 1.8 gray fractions.
So a higher boost than typical neoadjuvant if margins were negative.
A bit higher, yeah, reflecting the post-operative setting.
But what if the margins were positive? Or if there was actually gross residual disease left behind after surgery that needs more dose, right?
Absolutely critical difference. If you have positive margins or gross residual disease, you need to be much more aggressive with the dose to that area. The PTV-SR still gets 45 grays at 1.8 gray per fraction.
Okay.
But the boost to the PTV-HR, the area of positive margin or gross disease, needs to go significantly higher. We're talking 59.4 to 60 gray total dose.
60 gray, how do you deliver that?
You can use conventional 1.8 gray fractions, which would take you up to around 59.4 gray. Or increasingly common using SIB approach, or slightly larger fractions like 2 grays per fraction for the boost phase to get you up to 60 gray, maybe even a bit higher in select cases. The goal is maximizing local control where you know disease was left behind.
That's a big dose difference. Now, for patients who've had an APR, that abdominoperineal resection, what's the special consideration at simulation and for planning?
Key thing for APRs. You must wire the perineal scar at the time of simulation. Place a radiopaque wire along the external scar.
Why?
Because that scar represents the inferior extent of the surgical bed in the perineum, an area at risk for recurrence. You need to reliably identify it on the planning scan. Then, that scar area, usually with about a 1.5 centimeter margin, needs to be included in the target volume, typically receiving around 45 gray.
And technique-wise for post-APR cases?
IMRT is generally preferred in the post-operative setting, especially after an APR. The reason is that after removing the rectum, the small bowel often falls down into the empty pelvic space.
Ah, right into the radiation field.
Exactly. IMRT gives you the conformality you need to treat the target volumes while carefully sculpting the dose away from those sensitive small bowel loops. Much harder to do well with older 3D conformal techniques in this situation.
Makes sense. One last dose question. Lateral nodes, sometimes they need a boost.
Yes, this is a specific situation. If a patient has enlarged lateral pelvic lymph nodes, say, bigger than 7 millimeters initially, or maybe still enlarged, like over 4 millimeters, even after neoadjuvant chemoradiation, and if those nodes are not going to be surgically removed,
Then you boost them.
then you'd consider a radiation boost specifically to those persistent unresected lateral nodes. The dose target is usually around 60 grays, delivered using conformal techniques like IMRT or SBRT. It's targeting known bulky nodal disease that hasn't been cleared.
Okay, we've covered targeting the tumor extensively, but just as important, maybe more so sometimes, is protecting the normal tissues. Safety first. Let's talk organ at-risk constraints. The small bowel is always the big one in pelvic radiation, right?
Absolutely. Minimizing toxicity is paramount, and small bowel toxicity, both acute and late, can significantly impact quality of life. So when we talk constraints, we're usually looking at individual small bowel loops or sometimes a composite structure called the bowel bag. Let's focus on loops for now.
Okay, what are the key numbers for loops?
To limit acute and late grade 2 to 3 GI toxicity, we aim to keep the V35 gray, that's the volume of small bowel loops, receiving 35 gray or more, less than about 150 cubic centimeters, cc's. Some references say even lower, maybe less than 100 cc's if possible.
Okay, V35 less than 150 cc. What about higher doses?
The V45 gray, volume getting 45 gray or more, should be even lower, ideally less than 60 cc's, maybe even less than 20 cc's if you can achieve it. Keep high dose off the bowel.
Now, wasn't there a specific pearl about the V30 from a study related to late toxicity?
Yes, excellent point to bring up. From the Abraham PRO paper in 2020. A really useful guideline for late grade 3 or higher small bowel toxicity, again looking at individual loops, is to keep the V30 gray volume getting 30 gray or more below 200 cubic centimeters.
V30 less than 200 cc for late grade 3 plus spread.
Exactly. And for late grade 2 or higher toxicity, the recommendation was even tighter. Keep the V30 gray below 100 cubic centimeters. These V30 constraints are really valuable for long-term bowel health.
Great numbers to remember. What about the bladder? We use it as a spacer, but we don't want to irritate it too much. Constraints.
Right. For acute cystitis prevention, we look at dose volume parameters. The D50%, meaning the dose received by 50% of the bladder volume, should generally be kept less than 35 to 45 gray.
D50 less than 45 gray.
And the D5%, dose to 5% of the volume, which reflects a small high-dose region, should be less than 50 to 56 gray. Trying to avoid hot spots.
Yeah, femoral heads. Risk of fracture later on.
Yeah, we need to protect those. For late femoral head fracture risk, the D50% should be less than 30 to 45 gray, and the D5% less than 44 to 55 gray. Keep the dose down, especially the mean dose, if possible.
Bone marrow next. We're treating a lot of pelvic bone. Hematologic toxicity is a concern.
Big concern, especially with concurrent chemo. We look at the entire pelvic bone marrow sacrum, iliac crests, the acetabula, proximal femurs. To limit acute grade 3 or higher hematologic toxicity, the goal is a mean dose to this a whole volume of less than 20 to 30 gray.
Mean dose less than 30 J. Any volume constraints?
Yes, the V10 gray, the volume getting 10 gray or more, should ideally be less than 70 to 90%. Basically, try to keep some marrow spared from even low-dose radiation to maintain blood production.
Got it. What about genitalia, skin toxicity?
Yeah, for the external genitalia, penis, and scrotum in men, vulva in women, to limit acute grade 2 or higher skin reactions, the D50% should generally be less than 20 to 35 gray.
And the gluteal cleft. That skin can get quite irritated.
It sure can. We often contour the gluteal cleft specifically, usually as about a 5 mm rind of skin in the intergluteal fold. Same goal as genitalia. D50% less than 20 to 35 gray to minimize grade 2 plus skin toxicity.
And finally, for female patients, vaginal stenosis is a potential lead effect. Any constraint for the vaginal wall?
Yes, preserving sexual function is important. We often contour the vaginal wall, sometimes as a 5 mm rind around where a vaginal dilator would be placed. To reduce the risk of late vaginal stenosis, the D50% to this structure should be kept less than 30 to 40 gray.
Okay, a lot of constraints to juggle, but all crucial for safety.
It's a balancing act. Maximize tumor dose, minimize normal tissue dose. That's the core challenge.
All right, let's shift gears and distill this down. Time for some clinical pearls. These are the absolute must-know high-yield facts to lock away for exams and practice.
Love it. Pearl number 1, simulation prep. Remember the mantra. Full bladder, empty rectum, BFER, we'll come back to that. It displaces small bowel, improves reproducibility, and remember, prone on a belly board is generally preferred.
Pearl 2, CCVSR components. For that standard mid-rectal T3N1, like Mr. Chen, your 45 gray CTVSR must include these three things: the entire mesorectum, the entire presacral space, and the internal iliac lymph nodes. Don't forget any of them.
Pearl 3, neoadjuvant dose fractionation. Know the standards. Long course, typically 50.4 gray and 28 fractions. Short course, 25 gray, 5 fractions. And remember, simultaneous integrated boost, SIB, is a common, efficient way to deliver long course, often reducing treatment time.
Pearl 4, postoperative boost dose. This is key. After the initial 45 gray to the pelvis post-op, if you have positive margins or gross residual disease, you must boost that area to 59.4 to 60 gray for adequate local control. Don't underdose positive margins.
Pearl 5, the small bowel V30 constraint. Super important for late toxicity. To minimize late grade 3 or higher small bowel problems, keep the volume of individual small bowel loops getting 30 gray, V30 gray, below 200 cubic centimeters. Drill that number in. V30 less than 200 cc.
And Pearl 6, conditional nodal coverage. Don't automatically include everything. External iliacs are only for T4 tumors invading anteriorly. Inguinals are only for tumors invading the anal canal or below the dentate line. Know when to add them and when not to.
Excellent pearls. And for that simulation prep, let's try a mnemonic. How about BFER?
BFER, bladder full, empty rectum.
Exactly. BFER, simple reminder for displacing small bowel and getting that consistent setup. BFER, lock it in.
Nice. Okay, now let's move into applying this knowledge in the clinical decision-making segment. We've got the facts, the constraints. How do we use them? Back to Mr. Chen. T3N1 mid-rectal tumor, clear CRM, getting neoadjuvant long course. From a planning perspective, what drives that choice, and what flexibility or restrictions does it give us?
Great question. So the T3N1 status itself is the primary driver for neoadjuvant therapy. Even with a clear CRM on MRI, the node positivity puts him at high risk for recurrence without preoperative treatment. Long-course chemo-RT is the standard approach in North America for this stage, aiming to maximize tumor shrinkage and sterilize microscopic disease before surgery.
Okay, so the staging dictates the neoadjuvant approach. How does choosing long course impact our planning choices?
Choosing long course gives us, well, time. We have 5 to 6 weeks of daily treatments. This duration makes techniques like IMRT and SIB very feasible and advantageous. We can really leverage the technology to deliver highly conformal dose distributions, carefully sparing the OARs over many fractions.
This enables more sophisticated planning.
It does. If you were getting short course, for instance, the planning would be simpler, likely 3D conformal, because the biological effect relies more on the high dose per fraction over just 5 days. Long course allows for and often demands more intricate IMRT planning to safely deliver that 50.4 GICI or equivalent SIB dose.
Does it restrict us in any way?
The main restriction is simply the complexity and the need for meticulous adherence to those OAR constraints we just discussed. You have to meet those small bowel, bladder, femoral head limits while ensuring full target coverage. The flexibility comes in how you achieve that sequential boost versus SIB, IMRT beam angles, optimization parameters, lots of tools in the toolbox with long course IMRT.
And zooming out, how do these specific planning decisions take part? The technique, the precision, meeting constraints directly impact Mr. Chen, the overall outcome, and his potential future management pathways.
It's absolutely fundamental. The goal of neoadjuvant therapy isn't just to tick a box, it's to achieve the best possible pathologic response, ideally downstaging the tumor, maybe even achieving a complete response while minimizing treatment toxicity.
Which opens up options later.
Exactly. Meticulous planning that maximizes tumor dose while rigorously sparing OARs sets the stage for better surgical outcomes, potentially allowing for sphincter preservation if the tumor shrinks away from it, or just resulting in an easier, safer operation with fewer complications.
And what about organ preservation? We hear so much about that now.
That's where precision planning becomes even more critical. If Mr. Chen has a fantastic response to this long-course chemo-RT, maybe even a clinical complete response, he might become a candidate for a wash and wait or organ preservation strategy, potentially avoiding major surgery altogether. But that's only really feasible if the radiation was delivered safely, minimizing long-term bowel, bladder, and sexual dysfunction. The quality of the radiation plan directly enables or disables these less invasive future options. It underpins the entire modern philosophy of rectal cancer management: hit the target hard, protect the patient, maximize their future prospect for both cure and quality of life.
Excellent connection. Planning isn't just technical, it's strategic for the patient's entire journey. Okay, time to test ourselves. Let's hit the board blitz.
Ready. Case 1. 50-year-old woman, T3N1 mid-rectal adenocarcinoma, 8 centimeters from anal verge. Getting long-course neoadjuvant chemo-RT. Which of these is an essential component of her CTV-SR, the 45 gray volume? A. Entire pararectal fat, presacral space, and common iliac nodes. B. Entire mesorectum, presacral space, and internal iliac nodes. C. Only the primary tumor plus 2 centimeter margin and external iliac nodes. Or D. Only the primary tumor and inguinal nodes.
Okay, thinking back to our CTVSR pearls. For a standard mid-rectal T3N1, you absolutely need the mesorectum, the presacral space, and the internal iliac nodes. Common iliacs are usually too high. External iliacs and inguinals are conditional. So the best answer has to be B.
B is correct. Entire mesorectum, presacral space, and internal iliac nodes are the standard components. Well reasoned. Case 2. 7-year-old man gets postoperative radiation to 45 gray. Pathology showed a positive circumferential resection margin, CRM+. What's the most appropriate boost dose to the tumor bed for this positive margin? A. 5.4 Gui, total 50.4 Gui. B. 10.8 Gui, total 55.8 Gui. C. 14.4 to 15.0 Gui, total 59.4 to 60 Gui. Or D. 20 Gui, total 65 Gui.
Okay, positive margin post-op. Pearl 4 said we need to boost higher for positive margins. 50.4 is standard neoadjuvant. 55.8 is more for negative margins post-op. We need to get close to 60 grays, so 14.4 to 15 gray additional dose sounds right. That gets us to 59.4 to 60 gray total. Answer C.
C is absolutely correct. You need that higher dose, 59.4 to 60 gray dye total, to adequately address a positive surgical margin in the postoperative setting. Excellent recall.
All right, feeling good.
Final one, case 3. During daily image guidance for long-course pelvic RT, the CBCT consistently shows a significantly distended rectum, despite the patient following bowel prep instructions. What potential consequence is this most likely to cause? A. Increased dose to bladder. B. Increased dose to small bowel. C. Increased dose to femoral heads. Or D. Geographic miss of the primary tumor.
distended rectum. We talked about this during sim prep. If the rectum shape and position change drastically day to day because it's full of stool or gas, it's going to push the target, the rectal wall, and tumor around. While it might slightly shift the bladder or bowel, the biggest direct risk is that the tumor itself moves out of the high-dose region. So, geographic miss, answer D.
D is the VOFT answer. While dose to OARs might change slightly, the primary concern with inconsistent rectal filling or significant distension is the potential for a geographic miss of the rectal target itself due to its variable position. That's why consistent prep is so vital. You nailed the blitz.
All right. Now, stepping back again, we focused heavily on the how-to of planning today, but you mentioned controversies and advances earlier. We know the landscape of rectal cancer is shifting with TNT, organ preservation. How does this meticulous plan building we've detailed fit into those bigger picture philosophies and ongoing discussions?
It's the absolute linchpin. You can't seriously talk about advanced strategies like TNT followed by watch and wait or de-escalating surgery or using SBRT for boost or primary treatment in select cases without having the ability to deliver radiation with extreme precision and conformality.
The plan enables the strategy.
Precisely. Think about organ preservation. The whole premise relies on achieving a complete clinical response with chemoradiation and ensuring that the long-term functional outcome, bowel function, bladder function, sexual function, will be acceptable, hopefully better than after radical surgery. That requires minimizing dose to those critical organs, which demands advanced planning techniques like IMRT, VMAT, SIB, and rigorous adherence to OAR constraints.
So the precision allows for better functional outcomes, which makes de-escalation more palatable.
Exactly. The controversy might be, how much dose is needed? Can we shorten the course even more? Can we use highly focused radiation like SBRT more broadly? But underpinning all those questions is the assumption that we can actually deliver the intended dose distribution accurately and safely. Advances in imaging, motion management, and adaptive radiotherapy, where we adjust the plan during the treatment course based on changes in anatomy, are all pushing this forward, building directly on the meticulous planning principles we discussed. It's about refining our ability to hit the target harder while being even kinder to the surrounding tissues.
It really highlights how planning isn't just a technical exercise, it's integral to the evolving therapeutic strategy for rectal cancer.
Couldn't have said it better myself.
Okay, let's try and wrap this up with a quick summary of the key takeaways from today. I'll start. Optimal rectal cancer treatment planning absolutely begins way before treatment, with meticulous simulation and thorough patient preparation, that BFER protocol.
And then, accurate target volume delineation, following that wedding cake approach from GTV up through CTV SR and CTV-HR, is just critical for ensuring you're treating the right areas to achieve local control.
Next, remember that dose and fractionation are always tailored to the specific clinical situation, neoadjuvant long course versus short course. Post-operative boosts for adverse features or positive margins, and techniques like SIB can offer real advantages in efficiency and conformality for long course.
And overarching all of this, rigorous adherence to organ at-risk constraints is absolutely essential. Protecting the small bowel, bladder, bone marrow, and other structures is paramount for minimizing toxicity and preserving quality of life. Safety first, always.
A fantastic summary. It covers the journey from SIM to safety checks. And remember, this detailed planning is the engine driving many of the exciting advances we're seeing in rectal cancer care.
Well said.
To keep sharpening your skills, you can complete practice oral boards over at radonsmartlearn.com. That's radonsmartlearn.com. And be sure to subscribe to Radon Smart Review so you catch our next session. Thanks so much for tuning in.
Thanks, everyone.